Nothing I'm going to mention is as important as primordial prevention. But if you wait a couple years, you'll see plaque was CT. So on this side here are my disclosures. And for my talk today, I'm going to only focus on 3 parts. I'll talk about advances in technology in CT, which I think are very exciting. I'll briefly talk about how we use CT for acute chest pain, and I'll focus mostly on stable chest pain. So when we think about cardiac CT, what it is that we need from a good CT scanner, it's 2 attributes. The first is a high spatial resolution, which is the ability to see small structures. So as the resolution gets better, we get more accurate when we read a CT, and the better we can see plaque. The second thing is a high temporal resolution. So temporal resolution is, for those who are photography amateurs, it's kind of like the shutter speed on your camera. The faster your shutter speed, the better you can take a picture of a car that's moving and kind of freeze it so it's not all blurred. So let's first talk about temporal resolution, and that's really the amount of time it takes to take a picture. So typically with what we call a single source CT, the scanner has to rotate half a rotation because there's symmetry, so you don't have to rotate all the way around. So if the gantry rotation is 250 milliseconds, it takes us 125 milliseconds to take the picture. The advance that we now use is dual source CT often, where there's now 2 sources and 2 detectors. They're aligned 90 degrees to each other, and now you only have to rotate a quarter of a rotation to take that picture. So now that temporal resolution goes from 125 milliseconds, assuming the same gantry rotation speed, to 66 milliseconds. What's the implication? It's that we can freeze the motion of the heart a lot better, and we can get much better image. What about spatial resolution? There are a couple things that determine that, but one of the most important attributes is the slice thickness, and our best CTs up until just a few years ago had a slice thickness of 0.6 millimeters. I was always envious of my colleagues in the cath lab because they had much better spatial resolution. However, what's been happening now with CT was the introduction of photon counting CTs. The slice thickness has gone down to 0.4 millimeters, and now there's an option to even image with 0.2 millimeters with a mode called ultra high resolution. Why is it that photon counting detectors improve resolution? This is my only kind of technical slide that I will show, but on the left, using typical conventional detectors, we have X-rays that then hit a scintillator that converts the X-rays to light, and that gets converted to current. That's just how a CT detector works. When you use a photon counting CT, the X-rays get converted directly into current. So there's a semiconductor that detects the X-rays, and it gets converted to current. And the magnitude of the signal in this semiconductor is proportional to the absorbed energy of the X-ray. So no longer are you just detecting an X-ray, but you can see what's the magnitude of the signal. And in fact, this is a very good way to eliminate noise, because if you detect a very weak signal, you say, well, that's just noise. We're not going to count that. So hence, photon counting detectors. What does this all mean for our patients? It means that the newest generations of scanners have much better spatial resolution, and this allows us to be more accurate. This is particularly important in patients who have heavy calcifications. With CT, one of the big problems used to be what we called calcium blooming artifact. Calcium blooming, what does that mean? It means that the calcium is actually much bigger on CT than it is in real life. In fact, the calcium used to be 3 times bigger on CT than it was if we would actually dissect the heart, and we actually did those studies and looked at it under a microscope. So we have a lot less blooming, and we can actually now see, as in this case here, this is a patient who has a calcium score that's over 2,000, completely a valuable scan. We can see very well that these calcifications are really along the wall of the artery, and we can see the lumen very well here in the LAD and the RCA, and in fact in the circumflex we can see a complete occlusion of the left circumflex. This also helps us in stents. In the past, we always said, well, if you have stents, don't bother doing a CT. CT is not very good for stents. Well, maybe in large stents, but still, we discourage people from doing that. And now we can see a very nice resolution. Here's an example of a patent stent in the circumflex. With this scanner now, we can evaluate just about any stent now, including small stents. Just published in JACC a few days ago and presented at TCT is this study here from the St. Francis group looking at the impact of this on diagnostic accuracy. And what they found is when they, and this is not a head-to-head comparison, this is a comparison before they had a photon counting CT to afterwards, but the referral to invasive angiography decreased 13% to 9%, but the percentage of folks who get revascularized after being sent to the cath lab increases, which means you're referring the right patients who actually have disease. And then when they looked at the diagnostic accuracy, an increase in specificity that increases to 98%. That's a pretty good specificity because CT historically was a modality that had good sensitivity. And in fact, 20 years ago, 15 years ago, 10 years ago, we said CT is just a good test for ruling out disease. It has a good negative predictive value. I'm sure everybody's heard that. CT is good for ruling out disease. But when you have a specificity of 98%, CT is actually pretty good for ruling in disease as well. Let's talk about acute chest pain. Of course, a big problem. Lots of patients who come to our ER, $15 billion in healthcare costs. And the reality is that most patients have a negative workup no matter what test you do. This is a statement from 2014, so this is a decade ago. This is a guideline from AHA and ACC that stated that coronary CT angiography in the use of acute chest pain is associated with rapid assessment, a high negative predictive value, so that's again ruling out disease, decreased lengths of stay, we get people out of the hospital faster, and reduced cost. And the reduced cost was just a function of getting people out of the hospital because every hour in the ER costs, well over $1,000 just for the room alone. This was not a guideline indication. This was just in the text of the guideline. There were no indication, there's no specific formal indications in this guideline. Fast forward to 2021, the chest pain guideline is when there was for the first time, a guideline indication, and Dr. Bott was an important part of this chest pain guideline. And for acute chest pain, coronary CTA had a class 1 indication with a level of evidence, the LOE of A, and that was the strongest level of evidence. And that's because by the time this guideline was being written, there were already over 10 randomized controlled trials comparing CT to other modalities, and that's why CT had the strongest backing because it had the most randomized clinical data. The advantages of CT in the evaluation of acute chest pain include decreased time to diagnosis, decreased hospital lengths of stay, and those are advantages that I would like to call efficiency. It's just efficient to do a CT if you can do it faster. Part of that was because back at that time, 10 years ago, you needed to have 2 negative sets of enzymes before you could do a nuclear stress test or an exercise treadmill test. Today, with high sensitivity troponin, we can check troponin earlier, and you actually can get away with checking only a single high sensitivity troponin. So I think the advantage between CT and other tests have kind of diminished over time, at least the advantage of being able to do the test quickly. But CT does identify other alternative explanations to symptoms, showing on this slide here from left to right, a pericardial effusion, hiatal hernia, which quite often can be the source of someone's symptoms, a rather dramatic dissection going into the left main, or a penetrating ulcer or penetrating plaque in the descending aorta, which can be quite symptomatic. One of the advantages that I would think of doing CT is that we can detect non-obstructive plaque, and this could lead to better prevention therapies. The studies have been pretty disappointing on this, at least in the ER, in the acute chest pain. And the reason for this is when someone leaves the ER, we don't bother telling them, oh, by the way, you have a little bit of plaque. All we tell them is good news, you did not have an acute coronary syndrome, and that information does not always make it to the medical chart and does not always get acted on in terms of prevention. Things are different in stable chest pain. The last thing about acute chest pain that I'll mention is that in very high-risk patients, CT is really not going to be all that helpful. This is a multi-center study in Europe called the Discharge Trial, where they now took individuals who had suspected acute coronary syndrome, but these were high-risk patients. Many of them actually had known coronary heart disease, including prior PCI and prior CABG in some patients. Patients had elevated troponin or abnormalities in their EKG just to get into the trial. And the outcome here was a 1-year death or MI. And I think it shouldn't be all that surprising that in a high-risk group of patients presenting to the ER with elevated troponins, whether you do a CT or whether you go straight to the cath lab is not going to reduce this outcome at 1 year. So if you have a high-risk patient, they already should be on good preventive therapies, and perhaps they need to go to the cath lab. Doing a CT is really not going to be that helpful in these high-risk patients, and I think the discharge trial proved, in my mind, something pretty obvious. Let's talk about stable chest pain. So going back to our chest pain guideline, a class 1 indication for stable chest pain, a level of evidence of A, which was the strongest level of evidence of any modality for stable chest pain. However, in the guideline, there's other tests that also have a class 1 indication. A stress CMR, a stress PET, a SPECT, a stress echo. In fact, almost every modality here has a class 1 indication except for exercise EKG. We can talk maybe later why that is. But the big question then is, how do you select and how do you decide to do at a place like Sinai where you can do any of these tests? How do you decide to do a stress PET or a CT or a stress echo? And the advice that we provide in the guidelines is that CT may be preferable in younger individuals, not on optimal preventive therapies. And the rationale there is CT can detect plaque that we are not going to be able to see on other tests, and that's going to lead to initiation of preventive therapies. The other advice generally for stress testing is if we want to perform ischemia-guided management. That means that the more ischemia we see, the more likely we are to revascularize the patient or send them to the cath lab. For that particular strategy, the use of stress testing might be reasonable. On the other hand, if the objective of the test is to rule out obstructive disease and at the same time detect non-obstructive disease, this is where coronary CTA would be preferable. And importantly, we state here that there needs to be a high quality and expert interpretation routinely available. And that just makes sense. Not every test is available everywhere, and if you're going to do CT, you want to be at a place that can do it well. Why is it that the guidelines provide this high level of evidence? There's multiple studies, but I think one of the most important things is the fact that we now have data that when we use coronary CTA for stable chest pain, it leads to improved outcomes. The most important study that showed that was the Scott Hart study. This was in the UK, where they looked at adding coronary CTA on top of standard of care. Standard of care there was usually an exercise treadmill test. And in the Scott Hart study, over 5 years, there was a 41% reduction of MI or CHD deaths. So this was highly significant. These are curves that continue to separate over time. And the investigators suggested in a follow-up paper a year later in JACC that the reason that outcomes improved is not only were therapies, preventive therapies started, but they were started in the right patients, the patients who actually had plaque, and those therapies persisted throughout the trial. So there was better use of therapies, and there was better adherence perhaps to therapy as well. In the US, there was a different trial called the PROMISE, which was designed differently, had a different endpoint, which has actually ended up being a negative trial. But when they looked specifically at patients who have diabetes, who are a higher risk subgroup, and this is a subgroup analysis, so certainly a lot of limitations to this, but there was a 50% lower risk of CV deaths or MI in the PROMISE study in individuals with diabetes who are randomized to CT versus those who were randomized to other stress tests. So what is it that CT provides? I'll tell you that in the first kind of 10 to 15 years when CT was available, the thing we always focused on was stenosis. And of course, that's what we focus on in cardiology. Someone comes out of the cath lab, what's the stenosis? Was it 50%? Was it 60%? So in CT, showing here from left to right, minimal, mild, moderate, severe, or an occluded vessel. For the CT readers who may be tuning in, this corresponds to what we call CADRADS 1, 2, 3, 4, or 5. But we actually got this wrong. This is not always the most important thing on CT, so we came up with an update to how we should report CT, CADRADS 2.0. Whenever there's a 2.0 of anything, if your healthcare system is doing version 2.0, that means they didn't get something right on version 1.0. So what did we not get right on version 1.0? The fact that it's not just stenosis. We have to report how much plaque there is. So in version 2.0, we state that every coronary CTA should have a plaque score, what we call the P score, which is, depending on the amount of plaque, P1, P2, P3, or P4. And if you have P3, and there's various ways of how you can do this, with a calcium score, a segment involvement score, even just a visual assessment. If you have P3, we say you have a severe amount of plaque. If you have P4, an extensive amount of plaque. In either way, we state that if there's a severe amount of plaque, aggressive prevention is recommended. So now let's go back to guidelines. Do guidelines actually support treating or patients with plaque? And I think Dr. Fuster just mentioned something that I completely agree with, which is the guidelines are pretty primitive, especially I think your comment was with respect to the risk scores, that they don't very help, but also the fact that most guidelines have ignored subclinical disease. Nobody wanted to treat that until you actually have coronary disease. Well, in the chest pain guidelines, for the first time ever, we provided a class 1 indication that for patients who have non-obstructive disease, what we sometimes call subclinical disease, it is recommended to optimize preventive therapies, okay? By the way, the level of evidence at LOE is EO, that's expert opinion. You know, there's no trials, there wasn't very good trial data for this, but still a class 1 recommendation. 2 years later, the guidelines for chronic coronary disease now indicate that to actually diagnose coronary disease, you can use CAD based on imaging, including coronary CTA, and of course in this guideline, many therapies that we can consider in patients with coronary disease. So if we actually state that someone needs intensification of therapy, a common question is, well, what does that mean? If someone has plaque, what do you actually want to do? So that, first of all, starts with lifestyle. Exercise, something we can always talk to our patients, which is not just formal exercise, but also activity level. A diet, I'm a fan of diets that are predominantly plant-based, lowering saturated fat in highly processed foods. Diabetes management, we're learning more and more. There's going to be a talk by Dr. Casaubord later, both diabetes and obesity and cardiometabolic risk and the use of GLP-1 receptor agonists. More aggressive blood pressure control, antiplatelet agents, use of more aggressive lipid-lowering therapies. I think these are all things that we can implement once we know patients have a higher level of risk. A common question is, but is there really data for that? If I show this slide, and I used to show this slide, and people would say, this is great, but is this evidence-based that you can really recommend all these therapies just because someone has plaque on CT? And I would say that the evidence is kind of improving and increasing over time. It's kind of mixed, and I'll just walk you through that. For aspirin, most of the evidence is observational. It comes from MESA in the Dallas Heart Study, where individuals who have a calcium score over 100 are more likely to benefit from aspirin than to be harmed. Of course, this is an individual decision. So in patients who don't have bleeding issues, if the calcium score is very high, in my own clinic, I now sometimes use a calcium score over 300. If bleeding is not a big concern, that's an agent we would consider. PCSK9 inhibitors, can those be given to individuals who have plaque? There's 2 studies that are ongoing right now, outcome studies, that are enrolling, among other criteria, individuals who have plaque on a calcium score or stenosis on CT. This is the Vesalius study and the Victorian 1 PREVENT study. The CLEAR outcome study, which showed the benefit of bempedoic acid, one of the inclusion criteria was a calcium score over 400. We already talked about colchicine a little bit, but I'll still mention that in the Lovdoco 2 trial, a calcium score over 400 was used as an inclusion criteria. Even in the SPRINT trial, and this is a trial that's now well over a decade old, a calcium score over 400 was one of the ways for patients to qualify as having enough disease to get into the trial. And now future trials with lipoprotein A are also including plaque on CT as a way to get into the trial. Now, in the obesity space, I would say none of the trials are, at least the ones I know of, are using imaging by CT. But I would tell you, even in this field, perhaps we can use CT to identify who are the patients who are more likely to benefit from these therapies. So the SELECT trial will probably be talked about later on by Dr. Casaubord. But in our own healthcare system, we looked at our CT registry and looked at individuals who may fit the criteria for the SELECT trial because they have a BMI over 27 and they fit the age criteria. And if they had significant plaque on CT and specifically stenosis on CT, their event rate was the same as the control arm of the SELECT trial, suggesting that these are patients that even though they didn't have established cardiovascular disease, which was an indication to get into the SELECT trial, they have the same level of risk. So we use this construct to say that once you have enough disease, even though you may have not been included in a particular trial, you may have the same level of risk and perhaps you would benefit, or perhaps that would be a population to study in the future. So let's go back to how we actually report on CT. So this is an example here of a 59-year-old male, family history of disease. He was not on any therapy. His LDL is 106. You can see the rest of his lipids here. And we can see in the proximal LAD a mild stenosis, but this area of non-calcified plaque. When we look at the rest of his vessels, he has plaque throughout, and he got, on the report, a P3 score. P3 means a large amount of plaque. And in every report, we now provide recommendations. So the recommendation here is aggressive risk factor modification and preventive therapy. The question is, this is based on visual, this P3. We just looked at the scan, and we said there's a large amount of plaque. The future really is going to be quantitative plaque analysis, and we now have, in the US, 3 FDA-approved vendors who can do quantitative plaque analysis, which means provide the numbers. In this particular case, when that was performed, 241 cubic millimeters of plaque. And of course, everybody says, well, what does that mean? Is that a lot or a little? And I'll say that's a kind of moderate. But the important thing is also to look at the type of plaque. So in this particular individual, 90% of that plaque was non-calcified. And that's important because non-calcified plaque is the plaque that's more amenable to changes in therapy. The calcified plaque is not going anywhere. So that non-calcified plaque is a potential therapeutic target. The other question that folks often ask with CT is, what about high-risk plaque features? Can you actually look at a plaque and say, oh, that plaque right there is high risk and we need to do something about it? And the short answer is we're not very good at that. I think even in the interventional world, I think with trials like Prospect really never really panned out, a very low positive predictive value. But in CT, we have these high-risk plaque characteristics. They are associated with more risk. But once we account for the amount of plaque that individuals have, such as the calcium score, they no longer add for risk prediction. So this whole concept of high-risk plaque I think adds a little bit, but it's not, it hasn't truly panned out. And it's actually created a lot of anxiety for patients and clinicians because you get a report back. I don't know if anyone here ever gets a report back on your patient. It says that they have a high-risk plaque in the LAD. What do you do about that? And I say more aggressive prevention. Another tool in CT now is FFRCT. So this is a technique where we can use computational fluid dynamics to estimate what the invasive FFR would be. So this is a lesion in the mid-LAD here that's moderate. You can see here a short axis view here of the lumen and a large amount of plaque. And of course, this is a lesion that may or may not be flow limiting. If you're in the cath lab, you may want to do an invasive FFR, but now based on CT, you can predict what the FFR would be. The FFR we measure distal to the lesion, typically 2 centimeters distal to the lesion. Here it's 0.84, and similar to invasive FFR, if it's more than 0.8, we say it's less likely to be flow limiting. Data has shown so far that the use of this in a randomized trial called PRECISE was associated with less referral of unnecessary patients to the cath lab. So this may be a good gatekeeper if we see these moderate lesions, who needs to go to the cath lab and who doesn't. Another technique with CT that's, this is not yet FDA approved, but this is, I think, really interesting, a big study in Lancet that just came out on this a couple weeks ago, which is how do we look for inflammation on CT? This is a case of a 61-year-old male with psoriasis, chest pain, had a completely negative nuclear study. We were still suspicious, so we did a CT, and he in fact had 3 vessel disease. But when we look at the fat around the coronary arteries, this is called a perivascular fat or PCAT, pericoronary adipose tissue, we can see signals in this. These signals can actually tell us if someone has inflammation. So this perivascular adipose tissue could be a biosensor of inflammation. The reason for this is that when there's inflammation, there's cytokines that communicate between the coronary artery and the fat. There's actually breakdown of the fat. There's lipolysis, that's breakdown of fat. Then there's more edema, so water content in the fat. And we can detect that when we measure Hounsfield units. Of course, it's not that simple because you have to adjust for the KV and there's different values for different vessels. So it's not as simple as just measuring the Hounsfield unit on the CT scanner. But when we do all that, and this is really work that's been pioneered at Oxford University, and they deserve a lot of credit for this, this score that comes is called Phi score, and importantly, this has been shown on long-term follow-up to be a strong predictor of future events, even in patients who don't have obstructive disease. So if we have patients with plaque, perhaps those that have inflammation are the ones who are at higher risk, and we need to treat them more aggressively. I will just end with a quick discussion on lipoprotein A, because I think it's a really nice example that shows us where this field is going to go, is plaque imaging with CT. How is this going to be involved in therapeutics? So this is an example of a 32-year-old male. Dr. Fuster just told us age 30 is when he would start screening, and certainly I think that would be appropriate in this individual who has a lipoprotein A of 230 nanomoles per liter. And in this case here, of course, we first of all can see that he has plaque if you look at the images on the right, and no 32-year-old should really have plaque. That's always abnormal when you have any plaque at a young age. But when we go ahead and we quantify the amount of plaque here, 824 cubic millimeters, that's a large amount of plaque. 90% of this plaque was non-calcified. 10% of this plaque was a specific type of plaque called low attenuation plaque, which is lipid-rich plaque. Also kind of a high-risk feature. Why am I showing this? Because elevated lipoprotein A has been associated now in multiple studies to be associated with more plaque, more high-risk plaque, but also faster plaque progression. So not everybody with high lipoprotein A is going to have plaque, but people who develop plaque, that plaque tends to progress, and it may be higher risk plaque. There's also a study that was published just a few months ago in JACC. This is a study from China showing that plaque might be the mediator between who has a high lipoprotein A and who has an event. So first, back in 2022, we saw this was calcium score. The individuals who have a higher risk in MESA with a high lipoprotein A are the ones who also have an elevated calcium score. In fact, if you have a calcium score of 0 and a high lipoprotein A, your risk is the same as someone who doesn't have a high lipoprotein A. But adding to that now on CT, the individuals who have a high lipoprotein A in this study from China who had events are all ones who had low attenuation plaque. So they suggested this is really the mediator between high lipoprotein A and events. But the important part is this is now getting into clinical trials. So there's now a trial called ACCLAIM LPA for lowering lipoprotein A that's actually is one of the enrollment criteria, enrolling individuals who have not had a cardiovascular event, but have plaque on either a calcium score or a CTA. So I'm going to conclude here, and I'll mention that I showed all these great pictures of CT, and of course I'm very enthusiastic about CT, even though I also do MRI and I also do nuclear. But I always have to remind everyone that CT is not the best test for everyone. So someone with morbid obesity, massive calcifications, unless you perhaps have a photon counting CT or small overlapping stents, those are all patients that I would never sent to the CT lab. So we talked about the fact that improved CT detectors are improving our accuracy. I think this is a very exciting area. This is also going to be the accuracy to detect plaque, by the way. Among patients with acute chest pain, I showed you that the use of CT is associated with a more rapid diagnosis and decreased lengths of stay, so it's just an efficient test, but it may not lead to improved outcomes, and part of it is because outcomes are already pretty good in most low-risk acute chest pain patients. Among patients with stable chest pain, when we use coronary CTA, it's been proven now to be associated with improved patient outcomes, and likely the mechanism there is just that we can initiate preventive therapies and do so better than we did using alternative approaches. Quantitative coronary plaque analysis can improve risk assessment, and perhaps in the future, it may allow us to tell whether individuals are responding to therapy. This is one of those holy grails. I don't think the data is ready for that yet, but that's a potential way the data will go in the future. Thank you all very much.